been wonderful to see Sarah with boundless energy create this huge meeting and all the various aspects and all the variety of people that are involved. She asked me, because of my gray hair, to give a historical perspective on the ocular melanoma field. And so I think from time to time we need to look in the rearview mirror on our journey and see what has gone on in the past. As I finished my training 50 years ago, these patients with these ocular melanomas, there was only really one choice, and that's to remove the eye. And so that had been present for decades. That was the only option available. But actually patients did fairly well. A lot of them had a positive attitude, and they had a nice prosthesis. I think you can have a hard time telling which one of these patients, let me go back here, which of these patients actually has an artificial eye, but every one of them has one. So they actually function rather well. But at that time, there was a nice study done nationally at the Armed Forces Institute of Pathology, which was the center for eye pathology in the country, if not in the world, in which they did a study and found out eyes removed for melanoma, over 500 of them, actually 100 of them didn't have a melanoma in the eye. They had a benign condition. So that's 20%. That's not very satisfactory. And so a number of developments happened in the coming decades to help that out. One of them was the fact that there was more widespread use of these bright lights we put on our head. You're dilated, and it's not a comfortable light. But by doing that and dilating the pupils, then these tumors can be detected earlier before they really get too huge and are not being able to be treated. So that became more widespread around the country. And at the same time, photography was available, so the tumors could be followed. If there were a very small one, if it had any change in it, then it could be treated. At the same time, around the 70s, ultrasound became available for the eye, and now that's one of our mainstays of detecting and diagnosing melanoma. And for example, there's A and B scans in which you can not only tell the size of the tumor, but the characteristics of it. So you can rule out a hemorrhage or a benign lesion like a hemangioma. And so those developments were really quite helpful in making more accurate diagnosis. So the error rate from 20% really has come down in those years down to about 2 or 3%. And along that time, radiation began to be used to try and treat some of these tumors in the 1970s. But melanoma cells are pretty resistant to any treatment, and it takes a high dose of radiation to get them. And so a variety of things were tried, particularly a radioactive material, radioactive iodine, I-125, put on a little piece of, that goes, I guess that's not going right there. You can see this little plaque placed over the tumor. At the same time, proton beam were used from the cyclotrons in Boston and in San Francisco. So those were the treatments that were begun to be started. However, people had some reservations about whether that's going to be safe for the patients. Should you treat it with radiation, or is it safer to remove the eye for the long-term result? And so the collaborative ocular melanoma study was started in the late 1980s, and the questions were raised, two basic questions. For medium-sized tumors that were not too big, not half of the eye, was there any survival advantage to removing the eye versus using these radioactive treatments? And so the study was started, and we were invited in Denver to participate in that. And there were 40 centers around the country that were trained, and all these photographs and ultrasounds were sent to a central reading area, and it was a randomized trial. We could look the patient in the eye and say, I don't know which is the safest for you. Should we remove your eye, or should we use this radiation? And about half the patients said, well, I don't want a computer deciding that. I want treatment A or treatment B. And that's fine. Those were the two treatment options available. But half of the patients decided, you don't know, I don't know, I'll participate. So enough people were participating in the program that the study was conducted. It took about 10 to 15 years to come up with an answer. And so the question is, which is safer, radiation or removing the eye? Well, they found the survival was equal. So that gave a good answer. We were not anticipating, we were not hoping, well, partly we were hoping to have one of them be better than the other, but it ended up well because I didn't want to tell half the patients that you got the wrong treatment. But nevertheless, so your survival is just as good if you have the eye removed as opposed to using the radiation. So that was good news, and the study was concluded. And all these 40 centers around the country were now trained. At the same time, they did look at a lot of quality of life issues where they wanted to see, well, is the patient better off with the eye removed in terms of functioning and getting around? How do they drive at night and reading and interaction with people? And they really found out that in the first few years, if you had the radiation patch and still kept your eye, you did function a little bit better for the first few years. But as 5 and more years went by, actually people that had the eye removed functioned just as well. So it's not so at least we can tell the patients. I had one patient with a very small tumor, and he had strong family history of cancer, and he wanted that eye removed tonight, and we didn't do it tonight, but we went ahead, and he's functioning well. But I could tell him that that wasn't a wrong decision on his part, that he wasn't jeopardizing his survival. And so subsequently the trends in treatment then have come from 30 and 40 years ago, where 95% of the patients with melanoma had the eye removed. And now it's down probably less than 30%. Whereas the radiation treatments, either in the form of I-125 or other isotopes, has come up quite a bit. And probably the majority of people, probably 90, maybe 95% of people with a medium-sized melanoma in their eye will have the radiation in one form or another. And there are different isotopes that have been used. Cobalt was used before the iodine, and iodine, these radioactive palladium, ruthenium. Over in Europe, they tend to use more ruthenium, but the results are pretty much the same. So the other question that was answered by the collaborative ocular melanoma study was in large tumors where the patient just had to have the eye removed. There was already significant loss of vision. The tumor was half or 3/4 of the whole volume of the eye. We didn't know if the surgery itself spread tumor cells, because that can be true in other cancers, particularly in abdominal cancers. So they decided to take half the patients and have radiation to the eye before you remove the eye, a week ahead. And was that going to improve the survival? Well, the answer came back pretty quickly on that one. The answer was no. And because of this study then, it was not any longer necessary to have any of the patients undergo preoperative radiation, external beam radiation. So that was a help just for patient convenience and expense as well. So one of the benefits of having this national study was that now there's 40 additional centers. Virtually every major city in the country now has a center where these tumors can be diagnosed and treated with expertise. And I just want to mention too that the accuracy of diagnosis these days is quite high. So there's no longer 20% error in diagnosis. And in fact, in the COMS study, there was only one eye in 1,500 eyes that were removed that was a benign lesion. It was a hemangioma, but that's a pretty good record, 99.7. Melanoma is a rare tumor, as you know. There's only 5 or 6 per million people, and that hasn't changed. Compared with skin melanoma, which has had a dramatic increase in parts of the world, particularly in fair-skinned people, For every ocular melanoma, there's 20 people with a skin melanoma. So a lot of times a well-intentioned friend or family will see an article, oh, I hear there's a new breakthrough in melanoma, and it looks like they're curing this and that. Well, chances are pretty high that that has to do with skin melanoma. This is not to say that there won't be breakthroughs. There aren't breakthroughs, but there are definite ones. But make sure that your information refers to ocular melanoma. And in terms of other treatments that have been tried over these decades, I'm not opposed to things that are called alternative medicine, but I want that to be done in addition to medical care. The person on this side here, a woman in her 20s, she wanted to visualize the tumor away, and she didn't want any treatment for the eye. And that's a very treatable lesion too. And she passed away 2 years later. I don't know if it was because of the lack of treatment or not. In fact, we don't know all the biology, because here's a 82-year-old sheep rancher from northern Colorado who came in and he had this big tumor, and he said, oh, I'm kind of old, I don't want anything done. Well, when he was 90, the tumor grew so big that the eye was uncomfortable, and he had it removed, and then finally at 104, he died of old age. So we don't have all the answers, that's for sure. Along these past decades as well, other instrumentation has come about. You probably have OCTs, MRIs are done, PET scans are done nowadays to look for any other spread or any other tumors. And a lot of emphasis has come in since about the year 2000, thereabout, in genetic aspects of melanoma. And we know that skin melanoma is different than ocular melanoma because of the biology, the way it spreads and so forth. But it wasn't until about the year 2000 when actually son Peter and his wife Alicia and I looked at about 600 genes to compare skin melanoma with eye melanoma. And there's a little bit of overlap, but basically they're different biologically from the genetic standpoint. So that has led to a lot of different research. And now it's very nice that for all the people and the patients, they have a whole barrage of team members, oncologists, ultrasonographers, trained people with photography, medical oncologists, and genetic counselors, and all the social services, which you are part of. And I really congratulate Sarah for bringing all this together. You won't be quizzed on this at the end of the day here, but this kind of shows the depth of the research that's going on to try and come to some more effective treatment, particularly for the biology of not only the original tumor, but the metastasis. So yes, a lot of progress has been made and in the diagnosis and management of the ocular melanoma. And there still needs to be more, obviously. The remaining challenges are earlier detection. Dilating the eyes is going to help. Decreasing the side effects of radiation, that's being studied as well, because a fair number of the patients who have radiation to their eye will lose some vision over a period of 5 or more years. Although some patients have been able to, I had one fellow who's a pilot. He went back and he was flying airlines for another few years. And so that can help, but they're being looked at that. And of course, the better treatment for metastasis is one of the mainstays of the research that is being funded here too. So in summary, I'd like to thank Dr. Selig for getting this kind of a meeting together, getting all sorts of personnel in a variety of disciplines to address this topic, and her tireless energy to get this program continuing and thrive. So thank you very much.